Breaking news, woman delivers baby in dramatic turn of events. Meet our local heroes Amelia and Laura. We followed them on an average day to see what it was like in the daily life of a paramedic and came across something truly spectacular. Watch as we experience firsthand the miracle of childbirth as the girls give us a running commentary of their outstanding clinical practice. Okay girls, tell us what you're going to.
We've been dispatched to a 30-year-old female, imminent delivery. So,
with a case like this, we would expect to perhaps see the woman in the process of active labour, and so we just have to get there and hopefully it'll be a good outcome.
Let's see how it goes.
Thanks girls.
So at this stage we're predicting a normal birth. She's having contractions 30 seconds apart and there's no sign of a head at this stage.
I'm going to start getting some IV stuff together just to put a line in to prepare for potential complications as well as offer some pain relief if required. Here we note that the mother begins to push and the head advances through the birth canal and out through the vagina, just as it would in the case of a normal birth. In the case of shoulder dystocia, we observe that the head has delivered but the body does not advance. The anterior shoulder does not deliver spontaneously with good contractions. The head does not restitute and externally rotate. The chin burrows into the perineum as the anterior shoulder is caught on the symphysis pubis, known to be Turtle's sign.
We have now identified that this is not a normal birth, and we must therefore explain the situation to the mother whilst providing rest and reassurance. Request urgent backup in the form of mobile intensive care paramedics. Administer 100% oxygen via a non-rebreather mask. Document the time of the birth of the head. And finally, we must prepare neonatal resuscitation equipment. This is a time-critical emergency that must be resolved within 5 to 7 minutes. Fetal asphyxia is likely to occur after 6 minutes.
Correcting shoulder dystocia is best achieved by changing the position of the woman. There are several recommended manoeuvres, and it is here that we attempt to exhaust all external manoeuvres before Micah or a medical practitioner make an attempt to internally manipulate the fetus. The first position is the McRoberts manoeuvre. Attempts should be made to deliver the fetus for a duration of 30 to 60 seconds in this position before moving on to the second manoeuvre. This position is whereby the mother will pull her knees to her nipples with the assistance of paramedics. This manoeuvre causes hyperflexion of maternal hips, which allows rotation of the pelvis and opens the pelvic inlet to its maximum capacity. This action aims to push the anterior shoulder over the sacrum to facilitate its release.
The second external manoeuvre is to apply suprapubic pressure whilst in McRoberts position. The aim of this manoeuvre is to collapse the anterior shoulder of the fetus so that it is able to pass under the symphysis pubis. My hands are placed in a CPR position behind the mother's symphysis pubis. This should be done at a 45-degree angle along the fetus's back in an attempt to rotate the fetus forward. A firm downward pressure should be applied for 30 seconds, followed by 30 seconds of a rocking motion at a rate of approximately 1 per second. Gentle traction of the fetus's head should be maintained throughout.
The third manoeuvre should be carried out for 30 to 60 seconds and is whereby the mother is assisted to all fours, namely the Gaskin manoeuvre. The aim of this manoeuvre is to attempt to further increase the pelvic outlet diameter. Gentle downward traction is applied to the head throughout this manoeuvre in an attempt to dislodge the anterior shoulder of the fetus. The woman is likely to be extremely tired and this manoeuvre can be omitted in some cases. However, every attempt should be made to complete such an action. If unsuccessful, however, paramedics should continue to alternate between the Gaskin and McRoberts manoeuvres. As per evidence-based practice and the serious nature of this condition, a series of 4 recommended internal manoeuvres have proven to assist in a positive outcome with regards to shoulder dystocia. Each internal manoeuvre attempts to free the trapped shoulder and deliver the infant. Despite the fact that the following internal manipulation techniques are not currently available to Victorian Advanced Life Support paramedics, it is here that we wish to demonstrate best practice and the techniques that are in fact available to other healthcare professionals in Victoria and other ALS paramedics around Australia.
While suprapubic pressure is being applied, otherwise known as ribbon 1, ribbon 2 can occur. This is where the fingers of one hand are inserted into the vagina and used to apply pressure behind the fetus's anterior shoulder. This is done in an attempt to push the shoulder towards the fetal chest and therefore release the shoulder and deliver the fetus.
The second internal manoeuvre is known as the wood screw manoeuvre. Whilst maintaining the fingers in the same position as ribbon 2, fingers of the second hand are inserted in front of the posterior shoulder and used to add further pressure to rotate the fetal shoulders. Pressure is applied to rotate the posterior shoulder. Delivery should be attempted once the shoulder moves into the oblique diameter. If unsuccessful, the reverse wood screw manoeuvre is attempted.
Third internal manoeuvre is named the reverse wood screw manoeuvre. This action is performed post-failure of the previous technique. The reverse wood screw manoeuvre requires the health care professional to attempt to turn the fetus 180 degrees in the opposite direction, applying pressure to the back of the posterior aspect of the posterior shoulder, which is the opposite direction of the previously described wood screw manoeuvre.
When the aforementioned internal manoeuvres have failed, delivery of the posterior arm is attempted. The practitioner passes their hand into the vagina over the chest of the fetus to identify the posterior arm and elbow. Pressure is applied to the antecubital fossa to flex the elbow in front of the body, to grasp or apply pressure to the posterior hand and sweep the arm across the chest and deliver the arm.
Upon successful delivery, we place the neonate onto the mother's chest. We warm and dry the baby whilst monitoring both mother and child throughout transport to hospital. As we have stated previously, the neonate is likely to be compromised in the setting of shoulder dystocia, and resuscitation is likely to be required. In the neonate, the heart rate is the most important factor in regards to commencing resuscitation. The heart rate is best assessed by placing the stethoscope over the neonate's cardiac apex. Along with heart rate, overall tone and breathing effort are also important considerations. At this point, we will once again request intensive care backup if they are not already on scene or en route. The normal heart rate of a newborn is 100 to 160 beats per minute and should be consistently above 100 within 1 minute. If after 30 seconds since birth and after vigorous rubbing, stimulation and ensuring a patent airway, the neonate has a heart rate of less than 100 and or is not breathing, we will begin intermittent positive pressure ventilations at a rate of 40 to 60 per minute, aiming to deliver a tidal volume of 5 millilitres per kilo. If after 60 seconds since birth the heart rate remains less than 100, continued ventilations are required and high flow oxygen via the BVM is administered. If heart rate still remains below 60 beats per minute, CPR using this hand encircling 2-thumb method is to be commenced at a rate of 3 to 1. Compressions are then continued until the heart rate becomes greater than 60 and ventilations are continued until heart rate is greater than 100.
If delivery was unsuccessful of the neonate, the mother requires urgent transport in the McRoberts position with the left lateral tilt.
The receiving hospital would also be notified en route.